Thank you, sir. A very good afternoon to IAP Delhi and all its members. And it is indeed a pleasure to be here for the first meeting of 2022, when our hopes are high that we will have a COVID-free era beginning with us. I would like to thank Dr. Deepak Gautam, Dr. Pankaj, Dr. Anurag, and the entire IAP Delhi for giving us this opportunity to share our thoughts on hemophagocytic lymphohistiocytosis. I hope my slides are visible and I am audible as well.
So, everything is fine. Yeah.
Everything is fine. Go ahead.
Thank you, sir. So, the topic that has been given me is HLH from basics to conquering the frontier. And I'll just present the spectrum of disease that we have seen at Sir Gangaram Hospital and our own data, and kind of tell you that, how we have evolved in managing this difficult disease rather successfully over the last 10 to 15 years. So, to give you a clinician's perspective on this disease, I have put across all the cases that we have seen, a spectrum of cases, and I'll take you through them and show you how the management varies from patient to patient, from diagnosis, the underlying diagnosis, to the different, spectrum of etiology that we see this condition being triggered by. So the first case is a 3-month-old baby who was born out of a non-consanguineous marriage and was referred to us from a hospital in North Delhi. The child had fever for 1 month. The birth history was uneventful. The child was dull to look at. There was pallor and there was hepatosplenomegaly. The investigations revealed a hemoglobin of 8, a white cell count of 8,000, and a platelet count of 90,000. There was neutropenia present with 12% neutrophil, but we know that younger children can have a relative neutropenia that is, sometimes just, physiological. The peripheral smear did show some toxic granules. There were reactive lymphocytes and lymphomonocytoid cells. There was transaminitis, SGOT, SGPT was elevated, and the bilirubin was mildly elevated. Not significant for this age. The blood culture, urine culture, malarial antigen was negative, and the fundus for cherry red spot, because in a child with hepatosplenomegaly, who's a very young baby, that fundus examination is something which we can very easily do, non-traumatic, and that was negative. As always, most of these children who come to us with cytopenias, look infected, are started on IV antibiotics. We did get a call from the lab that the sample was highly lipemic, and we were wondering why that is. And, all these samples, it's kind of difficult to analyze this sample whenever there is too much of lipemia. With the cytopenias and the hematology consult being there, we proceeded with the bone marrow examination. So, this is for the audience. What does the bone marrow picture show? And you all can just look at it and think as to what is going on. But for the sake of time, I'll just move on and say that this is extensive hemophagocytosis, where we can see that, this one monocyte macrophage group of cell is chewing up red cells, platelets, and every white cells. And that is what probably is triggering the whole disease process. There was no evidence of malignancy or evidence of any storage disorder. So in such a situation where you have this baby with organomegaly and you have hemophagocytosis on the marrow, how do we proceed? So in this particular case, we evaluated the child for the basic HLH parameters, which were ferritin, triglyceride, and fibrinogen. And not to our surprise, the child had very high ferritin. The triglycerides were high, which were responsible for the lipemia, and the fibrinogen was low. Serum interleukin-2 receptor, which is available in Gangaram since 2014, we were the first ones to establish this investigation, was also quite high. The test does take some time for the report to come back. A diagnosis of HLH was made. The child was started on dexamethasone. What is HLH is the question that comes to all of us at this point of time. So HLH is a syndrome and not one particular disease. There are a lot of clinical signs and lab abnormalities that typify HLH, and it is mainly an uncontrolled proliferation and activation of cells of the monocyte macrophage lineage. Life-threatening hyperinflammatory reaction happens in these children, and it leads to multi-system manifestations. When do we suspect HLH? So if you have fever, which is not going away just by the simple treatment or by identification of infection and its management, splenomegaly is one of the criteria. Cytopenias, again, because HLH mainly involves chewing up of all the marrow precursors, so less hemoglobin. Thrombocytopenia, neutropenia are the typical cytopenias that we see. Hypertriglyceridemia, hypofibrinogenemia, hyperferritinemia, and high soluble CD25, which is the soluble interleukin 2 receptor that I just mentioned. These all are important criteria. If you are able to demonstrate hemophagocytosis, often bone marrow is the site which is easiest to do in these sick children. If you can do that, that really aids into making the final diagnosis. Low or absent NK cell cytotoxicity is the other important criteria. Now, if you satisfy 5 out of 8 criteria, we say that the patient has HLH. Now, why do you see this high serum ferritin in these patients? So serum ferritin is an acute phase reactant which is mediated by many cytokines. And all these cytokines are released at very high level in these HLH patients. There is increased erythrophagocytosis. And when these cells are breaking down, a lot of tissue injury is happening and the ferritin becomes very high. Ferritin more than 10,000 is highly, highly suggestive of HLH, although the criteria requires only a value of above 500 to satisfy HLH when other parameters are available. Why do you have high triglycerides? That is because when you have activation of macrophages, there is a cytokine storm, which is the main hallmark of this disease. This leads to increased level of TNF alpha, which leads to further decrease in the lipoprotein lipase levels, and this leads to high triglyceride. Why do you have fibrinogen, which is low? That is because of consumptive coagulopathy, DIC-like situation, decreased fibrinogen production because of macrophage infiltration of the liver, and increased cleavage of fibrinogen from fibrin, which is secondary to increased plasminogen activator, which again is released by activated macrophages. Now, this low fibrinogen can lead to a fall in ESR, like how we see in mass patients of rheumatological conditions. How do we classify HLH? So broadly, we say primary HLH or secondary HLH. Secondary HLH are those where we have a definite identifiable cause, like an infection, a malignancy, or rheumatological condition, which triggers HLH in a child. Primary HLH is generally driven by genetic inborn errors of immunity, which lead to the manifestation of HLH. Now, some people refer them to as familial HLH, where you have many genetic defects that can lead to HLH, and I'll come to that in a bit. Macrophage activation syndrome is a terminology which is frequently used by rheumatologists. When I speak to our rheumatology team, they feel that MAS and HLH are almost similar, in their disease pathogenesis and manifestations. It's just that when you have underlying rheumatological disease, some people prefer to call it as a macrophage activation syndrome. Cytokine release syndrome is another terminology that is used mainly for CAR T therapy or BiTE therapy, which is specifically used for leukemia patients. Why does HLH happen? Why do some children behave in a different way and just undergo this severe cytokine storm problem? So what happens when a virus infects or a tumor cell infects our body? CD8 cytotoxic T cells get activated, and these cells kind of try to destroy the virus infected cell. NK cells also play an important role in doing this process. So cytotoxic T cells and NK cells are important for our normal functioning of immune system. These lead to the release of perforin and granzymes, which lead to breakdown of these infected or bad cells. So you can see that this is a virus infected cell. You can see that there is a cytotoxic T cells, and when they are interacting, talking to each other, and the cytotoxic T cell is trying to kill this cell, it releases these perforins and granzymes, which lead to apoptosis in this patient, and that helps us fight, and that is what forms one of the basis of our immunity. Now, the normal immune system, if we look into detail, goes through many steps. So if you have a trigger, say a virus or something, and this trigger leads to an activation, now in these immune cells, they go through series of events: maturation, polarization, docking, priming, fusion. All these steps happen into these immune cells. Then what happens? An immunological synapse is there. And at that point of synapse, you see all this degranulation happening. And these perforin and granzymes lead to killing of these target cells, removal of antigen, and this leads to termination of immune response, and the body becomes quiet again. So this is a normal immune response. Now, in some patients, this does not happen, and this termination of immune response does not happen, and the immune response stays activated. So the trigger is there is an activation, and there is a failure to kill these target cells, failure to counteract the immune response, and you have an uncontrolled expansion of cytotoxic T cells and a continuous release of cytokines, which leads to clinical picture of HLH. Now, I was talking about the synapse. If the synapse between the virus-infected cell and the cytotoxic T cell remains for a long time, there is continuous overproduction of inflammatory cytokines, and the antigen-presenting cells keep on accumulating. More and more T cells are stimulated, and this leads to the cytokine storm and the immunological catastrophe. Would you like to investigate this patient further to find out the etiology, this little baby who came to us with HLH? Yes. And in this particular case, we looked at torch profile, which was positive for CMV IgM. That led us to do a CMV PCR in the blood, which was 82,000 copies. And we knew that this child has active CMV infection going on. EBV PCR was negative. Immunity profile was done because this child had very high CMV at a low age, but that was all, normal. So in this patient, we made a diagnosis of CMV triggered HLH, and this patient was managed with ganciclovir followed by oral ganciclovir, and this child improved. Do you want to look for genetic conditions in these patients? So ideally, they say that every HLH child should be evaluated for an underlying genetic disorder, and I'll come to that. In this patient, because of the very young age and a severe HLH manifestation, we did evaluate. We found a heterozygous HLH mutation, not a homozygous mutation, which was reported as uncertain significance. And because there was only this heterozygous and not a homozygous mutation, we decided this child to keep under follow-up. So normally, if you have homozygous mutations, you would go in the chemotherapy transplant way. But in this particular patient, we thought, okay, it has got a CMV triggered HLH. We managed the CMV, and 2 years post that episode, there is no recurrence of HLH in this child. And if there is further recurrence of HLH, we counseled the family that this child may be considered for a transplant. So no underlying homozygous mutation, and a definite trigger was identified in this particular case. We looked at our patients, that is 118 patients with HLH, and published data from Sir Gangaram Hospital in Indian Pediatrics. These patients were recruited from January 2010 onwards. It was a retrospective study with the median age of 4 years. And all these symptoms, that is fever was the main symptom, hepatosplenomegaly, neurological symptoms, because CNS HLH is also an important manifestation of HLH, and cytopenias were the commonest things that we saw. The median serum ferritin was 6,500. However, we did have patients with ferritin of, say, almost around 3 lakh. The lab used to call us and say, are you sure, doctor, what is going on with this patient? And we said, no, this is HLH. It fits into the clinical description. Primary HLH was identified in 23% of the patients, and the etiologies were infections, rheumatological conditions, and malignancies whenever we talked about secondary HLH. So this was our first case with a little bit of background of what HLH is, what is the pathogenesis behind HLH, and what are the investigations that we do for HLH patients. I'll move on to the next case, which is a 6-week-old girl. She presented with a 10 days history of persistent fever. She was tachycardic, tachypnic, And these were the findings at another hospital in South Delhi from where the patient was referred to us. The child required oxygen by nasal prongs. There was thrombocytopenia to begin with. There were some atypical lymphocytes. Workup for dengue, malaria, torch was negative. There was transaminitis. Cultures were negative. The child was given antibiotics because, I am talking about HLH. So HLH, we know that, every child has HLH. But when this child first presents to you, sepsis is always the first diagnosis because that is what we see very commonly. And most of the patients end up having some kind of sepsis or dengue or some kind of an infection, and we treat that. And that is what the first reflex for any doctor is. Even in our hospital, that is what probably our first reflex would be. There was worsening distress in this patient and worsening of all the other lab parameters as well, which included liver enzymes, platelets, and coagulopathy set in. The child was not showing improvement. Child got referred to us. And by the time the child came to us, the cytopenias were much worse. Now, evaluation revealed a very high ferritin, that is 90,000, high triglyceride, low fibrinogen, and serum IL-2 receptor also came out to be quite high. So we knew that we were dealing with hemophagocytosis, and the marrow showed that. Now, again, this baby is very young, just a 6-week-old baby, and always immunodeficiencies, malignancies are the things that, come to our mind whenever we see a sick child like this. Florid hemophagocytosis was documented. Further workup did not show a prelim immunodeficiency. The child was given dexamethasone after making sure that there was no leukemia. Supportive care was given, and the child gradually improved. Now, in this particular patient, primary HLH mutation came out to be positive for homozygous for perforin mutation. So this child had a familial hemophagocytic lymphohistiocytosis, which is an autosomal recessive condition. And these patients have to be managed by aggressive chemotherapy followed by a stem cell transplant. And if you do transplant for these patients, the outcomes definitely are much better. So with that plan in mind, we went ahead, gave chemotherapy to this child, and she underwent a haploidentical transplant from her father and is doing very well. So what are the genetic causes? So first one was a secondary HLH, and the second one is a primary HLH. You can have all these mutations in these children, which can lead to hemophagocytic lymphohistiocytosis, perforin mutations, UNC mutations, syntaxin mutations, and MUNG mutations are the common. They can also be associated with pigmentary disorders like, some forms of albinism like Griscelli-Chiriac Higashi, where you have this partial albinism in these children, and that kind of helps you to make the diagnosis. So as I said, we have all those steps in the immune system which are required for killing of the virus and killing of the malignant cells or the other abnormalities. And if you have defect in any of these steps, the docking step or the priming step or the fusion step, all these steps, if there are mutations, they lead to some form of a genetic form of a HLH. So the classification can be in this form where you look at the abnormal genes. You can have these, partial albinism and pigmentary disorders which are triggering HLH. And you can also have EBV-driven HLH where certain genetic mutations can predispose for a patient not to handle EBV virus properly. And I will not go into the details of this. This is a beautiful paper from India where, they have looked at multiple centers of, the experience of HLH, and it is available free of cost in Frontiers in Immunology. What are the diseases or conditions that lead to secondary HLH? So infections are the most common in India. Dengue, typhoid are the most common agents which lead to HLH. EBV is another very important reason why a patient can develop HLH. So often these viruses, bacteria, sometimes parasites trigger HLH in a patient, and we need to treat the trigger and the HLH improves. HLH is associated with a lot of rheumatological conditions. So our rheumatology colleagues are very active in managing what they call MAS in rheumatological conditions. And SLE, SOGIA are some of the triggers for developing HLH. Some of the patients who undergo stem cell transplant develop HLH, and there is a different kind of a pathophysiology in it. I'll move on to the third case, where this patient presented to us with high fevers and pallor. CBC did show anemia, and there were lowish platelets, and the neck nodes were quite big. So, whenever you see such a patient where there is anemia, lowish platelets, higher fevers, this patient was referred to me for this underlying condition with a suspicion of, some kind of a malignancy. The bone marrow, that is our first step, because leukemia is what we suspect. The bone marrow surprisingly showed that there was no leukemia and no infiltrate of any kind of malignancy in the bone marrow. The ferritin was very high, 12,000. So what would be the next step? So definitely their cytopenias are going on and the bone marrow is not showing the disease. So at that time, leukemia is ruled out. We need to evaluate this patient further for why this patient's platelet counts, hemoglobin is dropping. Is it because of excessive consumption, and why the ferritin is going very high? So at that point of time, we took this child for a lymph node biopsy, and the lymph node biopsy showed Hodgkin lymphoma. So this was a case with malignancy triggering the HLH in the patient. And if you treat Hodgkin lymphoma, the HLH will go away. So, although we think that, bone marrow will clinch the diagnosis, and then we have to tell the family, oh no, the bone marrow is kind of normal, or there is mild hemophagocytosis, which somebody could just ignore also. We had to go to step 2 for evaluating and making a final diagnosis. And this child did have a history of, being treated with antibiotics for 3 to 4 weeks and EBV being suspected. And, those were the common DDs, but I'm kind of skipping all that for the sake of time. And finally, we could make a diagnosis of Hodgkin lymphoma triggering the HLH in this condition. So malignancy-associated HLH is an important form of HLH that we see. When we treat the malignancy, the HLH improves. So, macrophage activation syndrome. And, people have been fascinated with differentiating these two conditions. Some say that, when mass happens, then the fibrinogen will be low, whereas in HLH, the ESR will be high. So, there's kind of craziness of the immune system being triggered by an underlying disorder, which leads to cytopenias, a high ferritin level, and thrombocytopenia, and low fibrinogen with high triglyceride. I move on to the next case, which is a 7-month-old child who presented with bruises and high fever. He was admitted with lower respiratory tract infection 3 weeks back. Now, this child's platelet were 18,000. Hemoglobin was 8. We live in India and 70% of our community has iron deficiency. So sometimes 8 and 9 is something that we ignore. And we think, okay, maybe it is iron deficiency, we'll give iron. TLC was kind of okay. Neutrophils were present. So because there was severe thrombocytopenia and there was some infection 3 weeks back, doctors suspected that there may be ITP or there can be a leukemia. Marrow was done. Leukemia was ruled out. There was some hemophagocytosis. Often in many, many hospitals, we do not have expert pathologists and they are actually not able to pick hemophagocytosis. So hemophagocytosis is often missed. And they just said, oh, there is no leukemia. Marrow looks okay. So somebody thought, okay, if the marrow looks okay, child has thrombocytopenia, this must be ITP. So the child was given IVIG. Although somebody did do a immunodeficiency workup because there was a history of lower respiratory tract infection. Commonly, ITPs are triggered by upper respiratory minor virus infections, or ITPs just happen without a trigger. The trigger is sometimes unknown. And whatever treatment was given, the child was a little better because there were kind of low IgM, there was a little bit, borderline IgG. And, these were the findings, and IgE was actually elevated. Because the platelets were kind of refractory, this child got referred to us. At that point of time, when we examined this child had a lot of eczema on the skin. The ferritin was 56,000, and DCT was positive, the reason for anemia in this child. So we can see that this child does have some features of autoimmunity. DCT is positive, ferritin is very high. So HLH is going on, which is probably leading to thrombocytopenia. And with the presence of eczema, we thought that maybe this young baby has got some kind of immunodeficiency. And one of the important immunodeficiencies that we see is Wiskott-Aldrich syndrome. So this patient's diagnosis was Wiskott-Aldrich. We did a simple investigation, mean platelet volume, which is available in all the Coulters. The mean platelet volume was low. The platelets were microplatelets. They were small platelets as opposed to ITP, which generally has giant platelets. And the diagnosis was clinched to be Wiskott-Aldrich syndrome, and we could prove that genetically. So please remember, some of the immunodeficiencies also can trigger HLH in our patients, and that is also one reason why you can have very high ferritin in young children, and always rule out immunodeficiency as the underlying cause for HLH, especially in very young babies. I move on to case 5, which is a 3-year-old female child who presented from Patna, Bihar during the peak of COVID Delta virus. So this child presented to the emergency. There was history of fever on and off for 15 days. There was abdominal distension, and there was progressive yellowish discoloration of the body. There was some rashes on the skin, and the child had fast breathing. Now, this child was evaluated outside, as I said, in Patna on day 3 of illness and received IV antibiotics, but the fever persisted. The child was evaluated at a second center because the child was not getting better. And on day 9 of illness, received IV antibiotics, but the child developed progressive cytopenias. They thought that the child has sepsis, but the child, was referred eventually to Gangaram Hospital after receiving 1 blood transfusion. Now, these are the outside investigations. You can see the COVID peak had just happened in India. And, everybody and anybody, any child who was getting admitted in the hospital was suspected to have MISC. So, look at the counts here. The counts are low, but look at ferritin is high, D-dimer was high, ESR was high. And when you see all these features, and especially, MISC was the leading diagnosis for every patient at that point of time. Rightly so, MISC was kept as one of the differential in this patient. However, cytopenias do appear quite striking. There was history of COVID 7 to 8 weeks back in the family. And that is why, one of the possibilities was MISC in this patient. Now, we did the COVID antibodies, and the COVID antibodies were very high. At that point of time, this was the child with the highest amount of COVID antibodies that we had seen in our hospital. And I know after that, we have seen many, many children with very high COVID antibodies. Cardiac markers were also high. So, again, the suspicion of MISC was strong here. The basic workup for all infections were negative, and the fever was persistent. When we did the bone marrow of this patient with this whole background, we really went down to the hematology lab to discuss, and they said that they could see a lot of hemophagocytosis at that patient. And 2D echo here was kind of normal for this patient. And we were looking at, from the point of view of Kawasaki or the MISC that is usually triggered. Now look at the blood counts in this child, and I'll show you this in the tabular column. And you can see here the ferritin was very, very high by the time the child came as 95,000. And see the degree of cytopenias in this child. So really, really marked cytopenia. The child was requiring a lot of blood transfusion, lot of platelet transfusion, which is typically not seen in other cases of MISC. However, the other markers were definitely positive. So we did manage this child like a proper HLH. Despite just starting on steroids and IVIG, the child was not getting better. The cytopenias were refractory. The child was sick. We had to go in, and after a lot of rounds of discussions with the PICU team, we decided, all of us, that we should go ahead and give etoposide to this child, that is chemotherapeutic agents. Normally for secondary HLH, we kind of withhold these chemotherapies. So say a COVID is triggering HLH or some other kind of virus is triggering HLH, we usually try to manage them with just steroids and supportive care, sometimes IVIG, sometimes cyclosporin. But chemotherapy and these strong drugs are kind of reserved for cases with primary HLH or refractory HLH who have not responded to the general HLH line of therapy. And this child did demand that because the cytopenias and all the other parameters were just not really budging. The child was sick. So differentiating MISC with HLH can be tricky. With Omicron, I don't know how much MISC we are going to see. But again, when you get flooded with these cases, there are leukemias, there are HLHs, and there are many other conditions which kind of are managed like MISC, and we kind of miss the boat because steroids are given in both the conditions, and we are likely to miss these dreadful conditions, and then the children can end up later. And not to our surprise, this child post-COVID with such a severe presentation where COVID triggered HLH or MISC kind of feature was something being thought of, this child also had 2 different mutations, compound heterozygous mutation, and we did identify a primary HLH in this condition also. So all primary HLHs, refractory HLHs will require chemotherapy as per the HLH study, managed best by a pediatric hematology or oncology unit. And this child underwent a transplant, post the COVID peak, and when we could control the HLH, a haploidentical transplant from the mother with the TCR alpha beta depletion, and is doing very well post-transplant. So, when we have looked at our paper, and I mentioned that earlier also, so treatment modalities that were used were steroids only for 42%. So a large population of these HLH can only be managed with steroids or anti-infectious agents to treat their primary disease, and multi-agent chemotherapy and transplants are required for the smaller conditions, smaller number of patients who have primary HLH or who have refractory disease. So far, we have performed transplant for 15 of these patients. It is to be noticed that, if these patients present with severe hyponatremia, hyperbilirubinemia, coagulopathy, or very high serum interleukin-2 receptor, they carry a poor prognosis. And these were the findings from our paper. And we did have high mortality. And believe me, we are getting smarter by the day in picking this disease early and, appropriately managing this condition. So we have many success stories to share of patients who have undergone transplant for difficult HLH, and many more who have been treated for secondary HLH by identifying the correct trigger and managing that appropriately. So I would like to summarize by saying that HLH is an aggressive immunoinflammatory disorder with dire consequences if not recognized early. Prompt diagnosis, good supportive care, and search for an underlying cause are important for having good outcomes. Treating the trigger, chemotherapy, immunomodulation, and transplant for difficult cases are used to manage this condition, and decision is mainly done based on identifying the underlying etiology. Thank you.